introduce Dr. Folks. Dr. Folks was called to serve as a career missionary many years ago, initially when he was at Asbury College in Wilmore, Kentucky. I think initially he was set to be a theologian, and he switched from that after his calling to pre-med. Subsequently, he attended medical school at Ohio State, and then did an internship at Mount Carmel in Columbus. He subsequently then went on to a surgical residency at Akron General Hospital, which completed his formal training. Then in 1958, he traveled with his then young family to serve at a newly planted rural mission hospital in the country of Zambia, which at that point was known as Northern Rhodesia. That's Mukingi Hospital. The hospital was located actually geographically in an area that was very dominated by the tsetse fly, which, as we all know, is the vector for African sleeping sickness. He served there for over 15 years, and during that time he supervised the treatment over 1,000 cases of Rhodesian African sleeping sickness, which is really incredible if you think about it. So I'd say he probably has more clinical experience than literally any other person on the face of the earth with treating at least East African sleeping sickness. This vast array of experience enabled him to publish his clinical experience in drug trials. In 1998, Dr. Folks was honored by World Medical Mission when Franklin Graham presented him with the Award for Excellence in Medical Missions. And I just told Dr. Folks I actually happened to be in the crowd, so I'm showing my age a little bit, but it was an honor to see him receive that award, and it was duly deserved. In 2002, Dr. Folks also received the Alumni Achievement Award at his alma mater, Ohio State University College of Medicine and Public Health. And today, naturally, he's going to speak then about trypanosomiasis. So, Jim, I'll turn the floor over to you.
Good. Thank you, Grant. And I would like to say a special thank you to Beth Thompson, sitting across from me, because I presented with her several months ago some lecture materials that I had prepared 25 years ago with my last sleeping sickness lecture, and I subsequently added a number of things, subtracted other things, and rearranged the whole thing several times. So thank you, Beth, for giving this a very, very effective, that I'm very pleased with this wonderful PowerPoint that helps us along. And thanks to you, Lance, for your encouragement,
yes, sir,
and help along the way. Sir. You might wonder why you're even hearing an old clinician like me present a bunch of material that I got a hold of a long time ago. And the lamentable thing really is that the treatment that I started using in 1960 is still the gold standard treatment for second stage sleeping sickness. And the next slide you will see a map of Northern Rhodesia, which is at that time Zambia, which shows in green the amount of Zambia that belongs to the tsetse fly. And that whole area is denied to man and his animals, who are very susceptible to an infected bite. The hospital is right kind of in the middle of the western zone, right there. Thank you.
Yes, sir.
You got it. And just another little comment about the green. Our hospital, 10 miles in every direction, you run into tsetse flies. So there should be a lot more green on that than there is. It was more than a third of Zambia belonged to the tsetse fly. And so that was a huge problem to all of Africa below the Sahara. About, roughly speaking, a quarter of Africa below the Sahara and above South Africa belongs to the tsetse fly. A huge problem economically. There are only about 10,000 cases every year, way back in those days, and I think they're probably about the same now. And so that gives you some idea of the scope of African sleeping sickness. Just a word about eradicating the fly before we move on is economically it's quite impossible. To eradicate 1 square mile costs multiple thousands of dollars, and they've done that a couple of times. In Zimbabwe, there were 2 ranches just with about that square mile in between, and because that was threatening their livestock, it was economically feasible to eliminate it. But 10 million square miles, no. The fly is often called the bane of Africa. That was the name of a book a long time ago for lay people, because this is the culprit that denies so much of Africa to mankind and his animals. A little attention to the proboscis there, which feels like a hot needle if it happens to hit a nerve and it goes in. If it misses in between 2 nerves, you don't even feel it at all. And so then he injects the anticoagulant, which allows him to get a full belly full of blood. When I say full, when they've had a good feed, the blood in the stomach is way larger than the whole rest of the fly. And so I might just mention that a med student came to help us out, as we always enjoy them year after year. He was obviously afraid. He heard we were a sleeping sickness center, and as a result, he was really running scared when we moved into the tsetse fly country. And so he's sitting right behind me in the Land Rover, and one was filling up with my blood on the back of the neck. So he hit me so ferociously, he almost knocked me out. And then I've got blood splattered all over my collar. But he thought he was saving my life. So I won't tell you what I said to him. Another interesting thing about the fly, though, is when it feeds, the head parts are down and the tail parts are up. And it's a very easy identifying factor there. You don't have to count the veins in the wings and all that kind of stuff. So it's very easy to fix them out 100%. And I might just say that rhodesiense is called that because a prospector in 1909 was traveling through the eastern part of Zambia and contracted sleeping sickness. When he got back home, he got very, very sick just within a few days. And as a result, that was the first case ever identified of Eastern sleeping sickness. And because it came from Rhodesia, it's called rhodesiense. But just for your help, I'm just going to talk about Eastern and Western sleeping sickness rather than talk about rhodesiense and gambiense, and to make it a little easier. So this is a picture of our hospital taken a long, long time ago. As you can tell, look at me now and look at me then. And so it was a long time ago. That's a student nurse. We've always been training nurses, and at this point they have 100 students at our hospital, 50 boys and 50 girls, and it's just been upgraded to the RN level. My wife taught them for 25 years, and we have no idea who's doing all the training there these days, but that's where they are. We were thankful to be plopped there. That hospital was the first hospital for well over 100 miles, and it still is the only doctor hospital for all that distance. We have looking after 50,000 people, and it is the surgical center for the whole province, and it was the treatment, the sleeping sickness center for all of Zambia. For a 20-year period, we were the only ones that even had the treatment, the arsenic, to treat sleeping sickness, because we were in the center of a huge endemic area there. So, the trypanosome is quite big and quite active, and you think it would be very hard to miss that because it's quite prominent, and yet it happens all the time. And so that was one side of the feature, that people would miss it that are untrained. And the other side was, I illustrate by a family at our sister hospital, which to get to the capital, they had to come through a part of the game park. And they had a flat tire, and they were all bitten multiple times with tsetse flies. They got back home, and they're all thinking sleeping sickness. And so the poor lab gal who was fairly new, had never seen a trypanosome before. And she was, with all this pressure on her, she finally found something that was quite different, and she called it a trypanosome. And so all of a sudden, this whole family are getting arsenic. And so after about a week of this, the medical director sent word to me, and he had really serious doubts that these people really had sleeping sickness. And so I made the trip down there, and it was quite embarrassing that when I looked at the first specimen, I said, I know there are no trips here, but I said, could you please point out to me what you've called a trypanosome? And when I shook my head, she started to cry because she had caused undue problems for the whole family. So that's the other side of diagnosing. You're looking for it or you're not. And it does cloud our wisdom. These are very hardy little animals, and when they're identified in a thick blood slide, it's still in the counting chamber. You can see them darting around rapidly 2 and 3 and up to 4 hours later at room temperature. And so they don't die very easily. They don't give up very easily, but they don't like arsenic, fortunately. They also, an important point is they do trick your immune system pretty quickly because they change their coat over and over again. Antigenic variation is a huge problem because these things are very smart. And your own immune system will probably not win the battle. In fact, as we're concerned, we call them all, they would be universally dead, a fatal disease, untreated. The local witch doctors know that, and they send them right to us because it's bad for business to have people die.
If they're going to die, they're going to die on your watch.
That's right. Really, they die for us. But actually, they don't all die. If they walk in, they will walk out. If they're carried in, they will be carried out to the morgue. And that is way too close to 100% true. Okay, next slide. Now, the presenting signs and symptoms, that was a large group that we had. That was probably 15 years after I'd been there. We had 1,000 by that time. We paid particular attention only to the symptoms that are related to the central nervous system, and you can see there are quite a few. And surprising that 40% of our cases were dull and lethargic when they came in, more than almost half of them had a serious enough anemia to be transfused before we would start arsenic. The change in gait was quite prominent, a very wide gait, was common enough to be up there. And again, comatose and semi-comatose, of course, they're the ones that are not going home. And the slurred speech and so on. I put Shanker in because we had one case that I will show you and tell you about in a little bit. And so those are the symptoms that we're very, very interested in an endemic area. If they had those symptoms in the city, they would be thinking of lots of other things because they don't see sleeping sickness. One of our missionary kids was home for his school holidays. He was at a boarding school in the Copperbelt town, and he started getting yellow. And he got sicker and sicker. His fever was going up and more yellow. So he's admitted in the big Mine Hospital where they have some very good doctors there. He tried to tell them, I've just come from my home where his father was the principal of our Bible school there, and I've been bitten a number of times with tsetse flies. They paid no attention at all the first thing. Finally, because that didn't look like any sleeping sickness, the guy's just jaundiced and got a high fever. Now he's 104 on the third day, and he's looking quite critical. So they found Tripp after he persuaded them. He probably had sleeping sickness. At any rate, they got in touch. They didn't have any treatment for it, and they got in touch with me, and I sent the treatment out, and I talked the doctor through the treatment, the rather complicated treatment regimen, and he survived, which we're thankful for that because he later became our international director of our mission and a very important person in the kingdom of God. I think the next one. The diagnosis by lab procedures, the thick blood slide is 80% of our cases are made by that. That's easy. We're thinking sleeping sickness, and we do it very early, and we do it often. If that's negative and there's still suspicious symptoms, we go ahead and concentrate it and spin it down, and then that gives us a lot more chance of finding trips. The hemoglobin and sed rate are, the hemoglobin's low and the sed rate is high, but of course those are not diagnostic. And I might say we almost will never treat a patient presumptively. We have to find the trypanosome itself. It has to be a parasitic diagnosis, because giving people arsenic, as we will point out a little bit later, is a very, very toxic drug, and you certainly don't want to introduce the dangers of that drug to someone that does not have sleeping sickness. So that's virtually 100% of our cases. We would deny them treatment until we find it. Then in the spinal fluid, if we haven't found it by that time, very late in the disease, the parasites get pretty scanty in the lymph and in the blood, but they're very much more they're easier to find and more concentrated in the cerebral spinal fluid, and so that is very likely where we would find them. And then go ahead and concentrate it if we don't have it there. And then the intraperitoneal, that's the final step, injection into white rats or white mice. They are highly susceptible, and we'll talk about that a little bit later. And that is the final searching point, is taking a little bit of blood from a rat tail, even on the third day. The protein and lymph count the protein and lymph are both of more than 100 milligram percent for the protein. More than 100 lymphs is really in about half of the cases. And the spinal fluid is very abnormal. Okay, next slide. Again, this brings that point up that the protein and the lymphs in the spinal fluid are very, very suggestive, and they're almost way up at that level. The thick blood slide is positive in 80%. In the other cases, we had to go ahead and find it in the spinal fluid or in the rat. The hemoglobin, half of the cases required transfusion because that was our rule. If it's lower than 65%, they must be transfused before giving arsenic. The urine it can be somewhat abnormal, but that is really insignificant in our treatment, in our diagnosis. Now, I need to say a few things about arsenic before we get into the treatment regimen, because it is the one drug that is very trypanosomiasis. It will clear the blood in just a couple of days. And I might mention that is a serious problem because with vast numbers of dead protein, of trips, the reaction to that is often a Herxheimer-like reaction, very high fever, and often death. It's a very high mortality rate if that happens. The form of melarsen, Mel-B as we call it, I'll just mention that's a combination of melarsoprol and British anti-leucite. The BAL is very important to protect the optic nerve, and a little later I'll show you a man that was blinded at our hospital long before I got there when they were just using arsenic without BAL. And so this is the combination. To have an antidote compounded along with the drug itself is very strange. I don't know. Do you know of any other drugs like that? I don't. But that is because this is a very, very toxic drug. So it has the antidote along with it as well. When I got there, we had 3 tropical medicine textbooks. All of them gave the same regimen for treating second-stage sleeping sickness. And they all started out with 5 cc's of arsenic. Some of them didn't even have Mel-B. They were still at trypanosomiasis level before. And 5 cc's would almost surely put you into a Herxheimer reaction. It massively kills almost all of the trips very quickly. And so by 1960, I discovered Robertson's regimen. Robertson was a wonderful clinician at EATRO, the East African Trips Research Organization in Uganda. And Robertson gave us all a great favor in this regimen of starting out very, very lowly with just a half cc's, not 5 cc's initially, IV, and on subsequent days upping it to 1 cc and 1.5. Then waiting a week, and then upping it to 2.5 every day, IV, and the third week, 3, 4, and 5, and finally, at the end of the month, you get the full dose 3 days in a row. And that is curative, and it has less side effects than any other regimen that was ever discovered before that. And so that was a very important contribution. After Robertson, there was another director that came along. After him was Dr. Onyango. I got acquainted with him because he paid me a visit. in Zambia. Several years later, I was in Uganda, the first time I'd ever been there, and I wanted to repay my visit. But a week before that, Idi Amin had taken over the country, and the president was in jail. Dr. Nyong'o was actually a relative of the president, so he was a marked man. The very night that it was obvious that Idi Amin was going to take over the country, he got in his Mercedes and drove over to Kenya, like so many other people did. Zambia was very blessed. They have 3 or 4 of them, and a whole bunch in the university that ran away from Idi Amin. It was a terrific brain drain, and those of us, the rest of us in East Africa, we benefited terrifically from Idi Amin. But it just said that closed that wonderful organization, and that was the end of the IATRO. Next year. Again, now we're talking about first stage, which we rarely made a diagnosis, but it is very important to pre-treat them before giving arsenic. And you have 2 choices there, either Suramin or pentamidine. They're both very effective. Pentamidine doesn't cross the blood-brain barrier well at all, and so it is of no value at all in second stage. And I'll point that out from a series in our own hospital. Suramin is very effective as well. It's a bit of a longer course. And I will point out a little later that the problem of assuming too much, that if the spinal fluid seems to be negative, that it's first stage. In our area, where all the people are partially immune, they don't have a first stage. They always come in second stage. And this acute phase, as we'll discuss, isn't part of it there. This is to illustrate that. I was on leave, and Dr. Foster was as well, and unfortunately, a lady doctor was there who had only been, she was raising a family, and we only saw her on Friday. So she had no experience at all in treating sleeping sickness, but there were 19 cases, way more than that, but 19 cases came in while she was there, and 19 of them had no sign of sleeping sickness in the spinal fluid as far as she was concerned. They had normal protein and only 3 or 4 lymph. So she assumed they were first stage cases and gave them pentamidine only. And as we later on we looked into those cases, 3 of them had relapsed within a few months. 2 others had died, and almost surely all 19 of them would have had some trypanosomes if she had done rat studies. There would certainly been some trips there, but they weren't as far as she knew. So at this point, it's very dangerous to assume in an endemic area that people could have at least normal CSF as far as we can tell, and that was a great mistake. Okay, excellent. Now, prednisolone, the worst complication of arsenic is reactive encephalopathy, and it's some kind of a combination between arsenic, a very toxic drug. I haven't mentioned it as rat poison, but that is rat poison, a very toxic drug. And so the so-called treatment was high doses of prednisolone. And so the assumption was, why not add prednisolone just 5 milligrams 3 times a day, routinely as an adjunct to the treatment. And this wasn't my idea, but one of the profs that I'll tell you about in a little bit, during the visit he paid, he said he really put a lot of pressure on me to do this study. He said somebody needs to do this because that would be a great help to protect against this terrible side effect, reactive encephalopathy. And so under his insistence, I did this study. We had 38 patients at that point that were part of it. We treated every other patient. We gave them the prednisolone, and the others, of course, got no treatment. At the end of the study, however, 3 of our arsenically protected patients developed reactive encephalopathy. In the non-steroid group, there was only 1. Well, there was, without question, that was the advantage of the study, that forget about using prednisolone as a preventive against reactive encephalopathy. Next thing. We had a patient that arrived, and he developed, he did fairly well under treatment. He was 2nd stage. So he had the Robertson regimen, and but he came back. He relapsed, came back again, and after the 2nd treatment, he came back at that point almost dead. He was loaded with trips. He was totally resistant to Mel-B. There is no treatment for resistant Mel-B. None whatsoever in the literature. There is no second line, but this guy is dying. I had remembered about a study I'd read a few years before that this combination of high-dose metronidazole and Suramin had cleared the trips from a rat. And so that's all I had to go on to try and save this guy's life. And because in those days, there's no ethics committee, or you don't have to worry about anybody looking over your shoulder. I'm trying to save a guy that's become my friend. So I started him off giving him 1 gram of Suramin IV once a week for 5 weeks. And high dose, who knows what high dose in a rat transmits into a human, but I gave him, which I think you would agree was high doses, 1.5 grams every 6 hours. That's a lot. That's 6 tablets.
That's Suramin?
Yeah. That's, I'm sure no human being has ever been insulted with that much flagyl. But he did pretty well the first week. In fact, it cleared his trips, and he was up and talking. You know, it was hopeful, because this guy was in coma. He's just about dead. So we're hopeful. I gave him a week's rest to recover, and Jay started out the 2nd week. About the 3rd day, the toxicity from metronidazole overpowered him, and we had to cut back because it was really affecting him mentally. And he developed a terrible diarrhea, and so I was giving him half of his tablets by rectum. That's all that kind of stuff's not known. In Africa, we use a lot of rectal drugs. You can't afford the IV for expensive drugs, but even flagyl itself, IV flagyl is very expensive. Very expensive. We gave it rectally all the time, and because we had it. And anyway, so to make a long story short, at the end of his month, he was clinically cured. His blood supplies, and we couldn't find it trips anywhere. His spinal fluid was normal. We brought him back every month for a year, and he continued to be negative. And in that case, he was cured, because that was the first case of anyone being cured of totally resistant arsenic. This was of interest, not just to us, but to other people as well. Though I got in touch with Dr. Kuzoy, who is the expert at WHO, and he agreed that I definitely should get this published. And he said, I'll help you write it up, and we'll put it in the transactions. That's the Bible in tropical, the transactions of the Royal College Tropical Medicine Hygiene. And the articles that I had published before, the editors of transactions wouldn't have been interested. I didn't even try. But Dr. Kuzoy, being who he was, very prominent in the small circle of sleeping sickness experts, got it published there. And so I certainly hope that someone else will pick that up. I'm about ready to retire. And the only reason I did that was because we had been out of Mel B ourselves for a while in the first place. So anyway, as far as I know, no one else has tried it, and it would be a little difficult to abandon a very toxic drug, but the one drug that does give about an 80% cure rate for some new treatment.
Jim, when I was in Panama, I was working with T. cruzi, Trypanosoma cruzi, and I accidentally injected myself with about 700,000 very deadly Brazilian strain. And at that time I did a lot of very drastic movements very quickly, but my treatment I chose for myself was 1,250 milligrams of metronidazole daily for 6 weeks.
Really?
Yeah, and
once a day.
Yeah,
and
I never converted. So that's not publishable because it was me that was treating me, but I never converted, and yeah, exactly.
Oh.
Yeah, so
no.
so it's and we had Dr. C. Carl Johnson with it. We had two Carl Johnsons. One was K. Carl, one was C. Carl. And C. Carl Johnson's an old Panama hen, and he had treated T. cruzi for years, and he used metronidazole as one of his drugs of choice. So, and I worked in the lab with him, and so that's the reason I chose what I did. But it's another case where, that drug is effective against trypanosomiasis, but in very high doses.
Yeah. Well, thank you for that.
Yeah.
Okay, we'll move ahead there. I'm embarrassed about this picture because the girls don't have gloves on, and then there they are. We're back into it. I can assure you that I prepared the scan and did the LPs, and I would go do something else. The students collected it, right. But we did have some gloves that are ready. But just as an aside, Dr. Dick Furman was there in Yankundi quite a few years ago. They were gluing patches onto their surgical gloves and doing major surgery with it. And as a result of that, as I understand it, that was the first container that Samaritans Purse ever sent out to anybody, with the whole container full of gloves. So anyway, but that was important. Sometimes we'd have 4 or 5, because we have outpatients. Yeah, we sometimes would have 4 or 5 lined up at a time. The node aspiration, I just show that is important in West Africa, but not in East. We totally gave up on them. That wasn't effective. It's too much trouble. And so, but in West Africa, they would still be doing aspirations of the node and finding trips there. Next. The rat KL was very helpful to us. because our trips were probably almost surely the most virulent in the world. And I mentioned this in an article that Dr. Omerod saw, who is in the London School of Tropical Medicine and Hygiene. And when he heard that, he was collecting trips from all over the world, all over Africa, and he got, I would call it almost lusting for our strain. And so he paid me a visit, actually, not too long after he got that word. And I didn't realize why he was coming, because he actually, the guy who did the taxonomy, he's one of the few real world experts, really. And so he was quite interesting because he wore a monocle. I'd never seen a monocle in a living human. They were in the movies. But, you know, they're quite wonderful. He just raised his, when he's through reading, he just raised his eyebrows, and the thing fell off, never touched by the human. Then it only took 2 fingers, and he plopped it right back in. So I was so impressed with that, I almost bought one myself. But he was, the interesting thing, though, is the day before he was leaving us, we got a new patient, and we injected 3 of our white mice with our strain. When he left in our small plane to fly back to London from the big airplane, he had 3 pockets with a white mouse in each one of the 3 pockets. And he got him back. So McKinsey strains are there right now in the lab in London. And he agreed they are by far the most virulent strains in all of Africa. It killed, they're teeming with trips on the 3rd day, and for most of 7 or 8 days before they cut a tiny little piece out of the tail and look at them. They're just teeming with trips on the 3rd day.
Jim, what would you, what fluid would you, you said you would inject fluid intraperitoneal?
Right, that's either the spinal fluid or saturated blood.
Yeah. Okay.
And we eventually just went to this spinal fluid, which is very, very effective.
Okay. How much would you inject, just out of curiosity?
Just a cc.
Okay.
That's plenty to go. Howard, it's a bit nuisance looking after mice and rats, and our lab tech
very effective.
Gave up on them after they're stinky, and she had a room off to the side of the lab. But eventually, I'm looking after them in one of our outhouses because we for 20 years we really needed it. Oh, yeah. Very important to us.
So are you saying you don't use them anymore?
Well, actually, the numbers are going way down, really.
So then, okay,
yeah.
I'm a nurse,
yeah.
with health interests. I'm wondering, so then when you use them out? After you've done that?
Euthanize them.
They die.
Yeah, they die.
Yeah, we euthanize them.
So you're not?
That's a good one. Euthanize them.
Right.
So,
I just was thinking, so you don't repopulate everything.
No, it killed in what, 7 to 10 days?
Yeah. They died of the disease, but we would probably put them under the mist.
Yeah.
And then incinerate them. Okay.
Thank you. Okay, next slide. There is quite a lot of difference between the immune and semi-immune. The semi-immune, they go right through the first stage. They might have a little headache or something and think they've got a bit of malaria, but they don't get sick because they really have a lot of immunity. I'm quite sure I did too. I was bitten thousands because I hunted. I was bitten thousands and thousands and thousands of times. And the one thing about, every 10th bite would be infected, and that is, of course, a bunch of baloney. So I've been injected with trips, no question at all. But my immune system kind of overcame, and I had a certain immunity. So I think I would have gone probably right through the first stage and got central nervous system symptoms as the first one. And so this is very acute, and I mentioned chancre because in the next slide you might show it. This unfortunately is my wife. We were in the game park. This is our second month in Africa. We were in the game park, and 40 miles away, Kafue National Park is just teeming with game. A wonderful experience. We had a great time. We were bitten just 2 or 3 times that we knew about. 10 days later, my wife began to have a red spot on her forehead, and we didn't think much about that. The next day, though, her temperature started going up, so you were thinking malaria. And so we started treating her for malaria, even though we couldn't find anything in the blood slide. This is a presumptive diagnosis that you don't do with sleeping sickness. And so so her temperature went up. The next day it was probably 101 or 102. And we gave her more malaria, doubled up the doses. The third day she had 105. She's critically ill. And the sad thing was Dr. Foster was gone. I don't know anything about it. I've been in Africa a few weeks. I knew nothing about it at all. And I realized my wife is burning up her brain cells, 105, and she's going to die in the next day. Dr. Foster arrived, entered the doorway, and made the diagnosis. From across the room. This, you can't see the chancre very well. It covers her whole forehead. Very, very obvious. So that saved her life. Contaminated, cured her. She was much better 2 or 3 days later. Unfortunately, the same thing happened to a Dutch volunteer 100 miles away. They waited until he was, probably 105. He died in the ambulance taking him up to the hospital downtown. That's the wrong direction. He should have come to us. But at any rate, he died. The first stage is very, very critical. You better treat them early. You get overwhelmed with trips, and they'll kill you.
So your wife just had first stage and contaminated.
That's right. That's all she had.
Yeah.
I'm not quite sure why Bob gave it intramuscularly. It works very well in IV, but intramuscularly it leaves bumps. Just another little comment. We thought it could be used prophylactically because we're all getting it. Those of us who are hunters all the time, and so I got a couple injections back there before we realized it's very dangerous for second stage because that's all it does. It leaves a big bump there for the rest of your life. And I'm not going to let you close mine, but it's still there. So my poor wife, on both sides, she's got 5 bumps that she had till the end of her life. Okay, maybe. Trypanosomiasis was an earlier form of melarsoprol, but it did not have BAL with it. This guy is clinically blind. He got arsenic with no BAL. The optic nerve does not like arsenic at all. And a number of patients, I never could find out how many, were treated before 1960 only with trypanosomiasis in their blindness.
Jim, who came up with the arsenic treatment?
I'm not sure.
Just why? Anybody, I guess, just trying to save somebody's life, you're going to try. Just enough not kill them.
That's right, and that was it was in the pre-antibiotic stage, but they're already using arsenic for syphilis and all,
Right.
And so I think that's probably what happened there. Okay. There are a lot of differences between West and East. I'm not going to use Gambian and Rhodesian, but this slide actually I copied from one I was asked to write a brief little article in the British Medical Journal. The Brits were still pretty interested in Africa. There still are much more. The British flag was flying over a lot of East Africa and Southern Africa. And so even today, they're much more interested in Africa than anybody in America. Right? And so I get anyway. And so they asked me to write this article. The guy that the editor didn't ask me. They asked an expert at the London School that I'd gotten acquainted with. So that's beneath his dignity to write a little article for lay people in Africa. That was the idea. The five African diseases. They wanted the general practitioners who read the British Medical Journal to know about these 5 diseases. That would have never been, the editors would have never thought about that in, the American magazine. But at any rate, this was it. It's a very different disease. Very chronic, slow, mild. And I might just mention that there was, tell you about briefly, a Ghanaian, a bright boy who was selected to go to the UK for university. 2 years later, he hadn't been back home. He developed CNS symptoms. And eventually somebody, after several weeks, somebody began to think he's from, they do have sleeping sickness there, and they discovered trips. We've been talking about first stage and second stage. They're all dead in a couple of months. 2 years later. So it's a very different disease. And so even the cycle is very different because man is part of the supply cycle because it doesn't kill them quickly. And on the other side, you've got wild game, fly, and wild game. Man isn't part of the life because it kills man. That would be the end of the sleeping sickness. And so man isn't part of the life cycle at all in the West. Definitely is. So there you have healthy carriers that carry around the trips for years and years, totally unknown for us. The palpalis is really riverine, and so unfortunately you get women and children going down for the water in the evening at the river, and they get infected. They infected more trips, and it can wipe out the whole village. Ours are in the savannas because the trips, they have to have a lot of cover. It's an occupational hazard for us. We don't see women and children. It's men who are hunting and fishing. Again, the lymphadenopathy is different, and so on. And so it's a very different disease. Okay, well that was the story I was going to tell you about the Ghanaian. I thought maybe I missed it. Yeah, on to the next. This guy was an early stage, a schoolboy. He had to get the whole month treatment, but he was really, he walked in and he walked out. Next slide. Arsenic causes a few other things besides reactive encephalopathy. This is not very common, and this isn't very bad, but we've had people slough a lot of their skin off that are really sensitive to it. Next slide. This poor kid was very sick. He was carried in, and he was carried out because he developed reactive encephalopathy, and he died 2 days with this high fever, and it wiped him right out. I'm glad we don't get many children because in male B, it closes your vein down. If you happen to inject it, don't ever do it. If it gets out of the vein, they will slough the skin over. You get a terrible reaction, and it sloughs the skin, not just give you a phlebitis. And so you start up down here and move up their arm, and then go down to with kids. Then you're running out of veins there. You go down to the leg, and finally we're up in the external. It's very difficult to get all this, to get all these injections into them. Next, please. I'm going to have to really. These are some guys that they started the richest copper mine in the world was 30 miles away. They brought all these local people in to work there. It's a highly infectious sleeping sickness, and here's 14 of them, except for the ones and so on. But so I made arrangements with the mine and gave them a whole bunch of stuff they were going to have to do, or we could close the mine, really, if they didn't do all these things. Because you can't kill people just because it's the richest mine in the world. It was done in 2 years. Okay. This guy, unfortunately, walked out. He's one of the very few that are carried in that with terrible brain damage. He spent the next 20 years around the hospital begging and so on. Poor kid. So he would really have been much better off if he died. Next month. And this guy had a very spastic side of it, which is a bit unusual, but he actually was cured and walked home. So what's happened in the 25 years since I've given this? This is only the second time I've given that in 25 years. So I had to look up a few things. In the Liverpool School, very prominent and important school of tropical medicine, they did say that if Lornithine, that's been around a while, and Nitrogenmox will probably take over as the main treatment for MELB in Gambiense, not Rhodesiense. But at the moment, MELB is still the gold standard. And that's certainly true in Zambia, in Rhodesiense. It is still the gold standard. I just want to say just briefly what Lancet had to say in 2010. Trypanosomiasis, it belongs to the most neglected tropical diseases. The clinical presentation complex, diagnosis, treatment difficult, available drugs old, complicated, and can cause severe reaction. New diagnostic methods and safe, effective drugs urgently needed. And that was hopefully money would have made a difference because there's no money in this. The people making MELB lose money on it. There's too few people, it's expensive, and to compound and so on. I was interested to find out, in doing a little reading there recently, the Gates Foundation gave over $17 million to the University of North Carolina. They had, I'll read what their requirements were, for the development of novel drug candidates for the treatment of African trypanosomiasis and leishmaniasis, which also has a heavy metal. I have no idea. I'm sure they've accomplished something, but in the 14 years they didn't come up with a treatment that has replaced MELB. Right. And we hope that some of the research might end up being there, but 14 years is a long time, and $17 million is a lot of money.
Yes, it is.
So we have question number 1.
All right, so we're going to conclude with questions here. Go ahead.
Good. The first question is the assumption that since high doses of prednisolone are an accepted part of treating the most serious side effects, the idea would be that if that was added routinely, that would be preventative for reactive encephalopathy. The question is, did the drug trial support this assumption, yes or no?
And so you guys out there with the polling questions, you can go, let's see, should be popping up here. Just 1 second here. Well, let's see. I am not pulling it up for some reason. That's odd. Anyway, let's go ahead and it should. We'll just have to answer them then corporately. Do you all think the answer is yes or no? Anybody? Huh?
Can you just have them type it in the...
Yeah, you can just, in the chat box there, if you just want to type the answer, do you think the answer is yes or no? Very good. And that is correct. The answer is no. And remember, you guys, this is for CME, so when we send out the invitation, there was that attachment. Make sure that you submit your answers to Orlando Health, and you will be awarded credit. Okay. And number 2?
The addition of British anti-leucite to trypanosomiasis eliminated one of the most serious side effects. What was the side effect? There are 5 choices: impaired sensation, deafness, blindness, motor weakness, renal failure.
Okay, you guys, I have figured out my mistake there. So if you go right at the top there, and you'll see there, there's choices A through E, and you just select the answer that you think is correct. And I'll give you a minute. Oh, we got a smart audience here. All right, yeah, and the answer is blindness, C. So the addition did eliminate the side effect of blindness. Okay. Number 3?
Yeah. I might just say that, the optic nerve doesn't like arsenic.
Right.
And the BAL is almost, it is, in our hands, 100% protective.
Okay. Do you want to go ahead and do number 3?
Yeah, 3, yeah. The continued presence of vast sections of Africa that still belong to the United States, that still represents today the vein of Africa. What is the best way to eradicate the fly? Again, there are 5 choices. Introduce the use of sterile males, utilize fly traps, spraying from the air followed by fogging from the ground, clearing forests, or none of the above due to economic impossibility for such large tracts of territory.
And if you put E, you are correct. And it looks like everybody did. So, all right. Yeah, very good. All right. 2 more.
Not very good.
Yeah. No. All right. Number 4, Jim.
Yeah. Mm-hmm. What is the accepted drug for treating arsenical-resistant Rhodesian trypanosomiasis? 5 choices: nifurtimox, pentamidine, eflornithine, all of the above, none of the above.
And you guys were listening, so the answer is E. All right, and last one.
In 1958, most tropical textbooks advised that the initial dose of arsenic should be the entire 5 milliliters of the ampule. Is this still standard of care for practice, for treatment?
And a lot of red X's up there, so that is correct. The answer is no. If you'll recall, the side effects from that large dose was overwhelming and killed too many trypanosomes and created that Hersheimer reaction. So, very good. Well, we are about to conclude here. Does anybody have any questions for Dr. Folks before we draw it to a conclusion? Dr. Folks, that was a phenomenal presentation. We really appreciate you. You obviously put a lot of time. I'll brag on him a little bit. He's really a pioneer medical missionary. There's very few left, and although World Medical Mission is generating a new generation of career medical missionaries, but he wrote a book, To Africa with Love. If you'd really like to learn about his experiences, then I highly encourage you to read that book. He can tell you some phenomenal stories about Africa and Rhodesia. So I really encourage you to read that book. I'm going to stop the recording.